Lusaka Provincial Health Office. I see. So Dr. Chitalu Chanda says he's failing to unmute, but he's on the call. Thank you so much. I'm sure IT will change the setting momentarily. I see Dr. Himabala from Central Province. Dr. Himabala, are you able to unmute and just say hello to the network?
Yes, Dr. Muhuma, good afternoon, and good afternoon to the network. Thank you.
Thank you so much, Dr. Himabala. I see we've got representation from Unza Clinic. Good to have you on the call. I was recently in Katete, Eastern Province. I see Dr. Muka has joined us from Katete. We have Gift Nkana, we've got Edward Chama from Chawama Sub District. Dr. Sale, we recognize your presence. Kay is saying my sound is too low. Dr. Mwape, Dr. Francis Mwape, can you get me clearly?
Good afternoon, Dr. Muhuma. We can get you loud and clear.
All right, thank you so much for confirming. Just one other round of call. Dr. Mundia, have you joined us? Dr. Malumani. Dr. Webster is saying I'm actually very loud. So, dear colleagues, thank you for joining us. We are just over 230 participants on the call. I'd like to welcome you all to this session, just as a way to repeat for the ones that have just joined us. We are looking at approach to the management of STIs and its role in prevention of HIV transmission. We have an able team that is going to take us through most of the discussion. We will start off with a case presentation. This will be done by Dr. Paul Kalombo from Livingstone, UTH. And then we will have a Q&A discussion for just about 10 minutes. So this session, the case and the Q&A should take not more than 30 minutes. After that, we are going to have the didactic presentation done by Dr. Malan Malumani, who is also a consultant dermatologist. Among the experts, we have Dr. Owen Galamika, we have Dr. Mundia Mitumwa, we have Dr. Teddy Kajimotu, and Dr. Chitalu Chanda. I know Dr. Chitalu Chanda is on the call with us, and we'll be able to follow the discussion closely. So just remember to keep your mics muted if you haven't been asked to speak, because when your mic is unmuted, it disturbs the flow of the conversation that we are having. Also, remember, if you want to make a comment, please utilize the chat box or indeed raise your hand and we'll be able to get to you. So as I said, we'll allow the case presenter to do the presentation first, and then at the end, we'll allow for some questions and some just a Q&A section after the case has been presented. But while the case is being presented, please use the chat box if you have any issues that you want to raise, and we'll get to them. Without further ado, I want to invite Dr. Paul Kalombo from Livingstone to take us through the case. The time is 14:40. We expect that this case presentation should not take longer than 10 minutes. Then after that, we can have a discussion around the case. Dr. Paul, are you ready? Will you share from your end?
Good afternoon, Chair. Yes, I'm ready to present the case.
Okay, please go ahead and share the case, and then we can follow through.
Okay, good afternoon, everyone. Good afternoon, network. My name is Paul Kalombo, medical doctor at Livingstone University Teaching Hospital. I'm presenting this case on behalf of Livingstone, UTH. Just have to inform network that the presentation contains some images, but permission was sought to have the images used for echo session. So I can go to the case now. So the case is Miss Kehem, female, 30 years old. Am I audible?
Yes,
Yes.
audible.
Yes.
Okay,
Yes,
thank you. The case is Miss KM, female, 30 years old, a referral from Dambwa Clinic to Livingstone UTH for further management of genital growth. Seen at the hospital in OPD, it was concluded to genital warts, and the patient was sent to dermatology clinic to be seen by a dermatologist. There, she complained of genital growth for 2 weeks, increasing in number, producing serous liquid. And no any other complaint was noted, and the review of systems was unremarkable. Medical history, she's known HIV positive on ART and virally suppressed to less than 20 copies per ml. A CD4 cell count was 714 cells per microliter. On drug history, on ART, TOD, social history, she enjoys alcohol and smoking. She's a sex worker, a KP, and with no consistent use of condoms. On physical exam, her general condition was good, no pallor, no jaundice, no cyanosis, no skin rashes. The vagina examination revealed lesions on both labia majora with seropurulent discharges. These are the picture we managed to get from the same client. I think on the left side, you are able to see more than one lesions, because on the right side, the labia majora was covering them. So you have to lift and get photos. On management plan, our impression was condyloma lata in RVD, KP patients. Our plan, some lab requests, some lab were requested, some lab tests were requested, CD4 cell counts, viral load, and full blood count. RPR, which came out positive. Treatment, she was put on benzathine penicillin injectable, where she received 2.4 mega international units, IM weekly ×3. And she was asked to continue with ART. Unfortunately, this client never came back to the facility for review after completion of our injections. These are the lab results. CD4 was 714 cells, HB 12 gram per deciliter, VL less than 20 copies per ml, and RPR was positive. Our questions: what would have been the best approach to the clinical before referring this client for tertiary care? Since this client is non-KP, female sex worker, how do we approach the issue of contact tracing for the STI? The third question, is there anything else that could have been done for this patient who is at continuous risk of STIs in view of what she does. Thank you, Chair. Over to you. It's less than 10 minutes.
Thank you so much, Dr. Paul. Actually, less than 5 minutes, and straight to the point. Beating about the bush, and I think the network appreciates this. So, dear network, we are looking at a 30-year-old female who's a female sex worker and is on treatment, is on ART. She is presented with a of serious liquid genital growth, has a positive history of alcohol and smoking. And you've seen the pictures, and you've seen that the team think that this was condylomata. Sorry, I was getting some feedback. Yeah. So as you can see, there are questions. These are their questions. What could have been the best approach at the clinic before referring for tertiary care? And the second question is, since this client is a known KP, that's female sex worker, how do we approach the issue of contact tracing for STI? For those that may not know, when we say the known KP, we're talking about key population, female sex workers, men who have sex with men, and the like. And the third question is there anything else that could have been done for this patient who is at continuous risk of STIs in view of what she does? So that is the case from Livingston UTH. Our first question, Dr. Paul, will come from the chat box. Malambo is saying no treatment given for genital warts. Could there be a reason for this? After this, then we'll take 3 questions first. The first question is, could there be a reason for non-treatment of the genital warts? Then Ray Shemu, you can unmute and give your comment or ask your question or give your contribution. Ray Shemu.
Hello, good afternoon. With me, it's not a question, it's a response to one of the questions that have been asked. So I don't know if I can go first, or perhaps we start with questions.
Let's get a few questions or clarifying questions, and then we'll get back to you, Ray. Thank you for that. Just hold on to your thought. Mavuto. You can unmute. Mavuto Simwinga.
Am I audible? Am I audible, network?
Yes, Mavuto, please go ahead.
Okay, thank you. Yes, that was a very good case, and it was well summarized by the doc. So for me, I know we are discussing STIs. I wanted to find out if they had, if they thought of doing a cervical cancer checkup, looking at this person who presented with those lesions, which might be HPV lesions, but we know for cervical cancer, also other types of HPV can also be detected. So I wanted to find out if they thought of any cervical cancer screening. Thank you.
Thank you so much, Mavuto. And the third question, Dr. Paul, will come from Dr. Humphrey Chanda Kamuliwo. Were titers done for syphilis? Titers, were they done for syphilis? So you can tackle those 3 questions first, Dr. Paul. As a reminder, the first one is treatment for genital warts wasn't done. Is there a reason? Then Mavuto's question, CA cervix checkup. Did you do that? And then lastly, Dr. Chanda is asking, were titers done for syphilis? Dr. Paul.
Yes, good afternoon. I didn't get clear the first question. Let's start with the second question. Thinking of doing cervical cancer, it was actually advised to the client that she needs to come for cervical cancer. But unfortunately, she went on.
I hope the network can hear you clearly. You're not very clear on my end. Just adjust your microphone.
Am I audible? Hello, Chair.
Yes, please go ahead. Loud and clear.
Okay, I was saying this. For the second question, we really advise this client to come for cervical cancer. We didn't do it on the spot when she came, but we discussed this with this client on cervical cancer. And she agreed, but unfortunately, she never came back from the time she completed the medication. She never returned for cervical cancer screening.
All right. So the second question, CS cervix, you say the patient, you advised that it was supposed to be done. Then the treatment for the lesions, why wasn't it done? Someone's asking.
Treatment to the lesions, we thought by giving what we are giving, benzathine penicillin, will also help to treat those lesions. So the way they were looking, yes, we thought of to do some specific treatment, like prescribing podopilin or something else. But I thought with the medication we're giving, that helps to clear them. That's why we gave the 3 injections and we're waiting for her to come back and we'll see the response before we thought of something else. Excellent.
Hey, Dr. Paul, are you able to just adjust your microphone? We are straining to hear you. Please try again. A number of comments actually are saying you're not very clear. Livingston UTH? Can you hear me?
You're not audible.
Hello, Chair.
Hello.
Is it the volume?
Dr. Paul, please go ahead. When
Hello, Chair.
Yes, when you use that device, HP, I think we can be clear.
We can, okay. Thanks so much. Am I audible now?
Yes.
Yeah, to the third question.
Loud and clear.
Why we didn't treat the lesions. So we thought of, by giving benzathine penicillin, it was a way of treating them. Benzathine penicillin would have helped to dry the lesions and to clear them. This is why we thought of first finishing the course and see how the response will be. But as you know, the patient left without coming back after finishing the injection, the whole 3 injections. But we thought of, actually, there was some improvement just by giving benzathine penicillin. We would see some improvement on this client. I submit.
Thank you so much, Dr. Paul. Dr. Jacob Ngambi and Mervin from Katete DHO have confirmed what you're saying, that the lesions could actually be syphilitic and would disappear on treatment. The last question was, did you do titers for the syphilis?
Titers, we didn't do titers because it's like we never had reagent to do that. Yeah, we didn't do. We just did RPR. Submit, Chair.
Okay, thank you so much. Do we have any other clarifying questions from the network? Mwenya Mubangai, not your question, but we'll address it just at the end. Kay is asking, was there improvement both on the lesions and the warts? Because the warts were protruding. I don't know if you have an answer to this question, Dr. Paul, because you said the patient didn't come for review.
Yes, I actually answered. I said during injection, when she came for the first injection, she came back for the second injection. We could see some improvement on the lesions. They were actually, the response was actually good. Just looking at benzathine penicillin alone, would have seen some improvements. But unfortunately, this client never came back to see the final outcomes. But there was some improvement just with benzathine penicillin. I submit.
Okay, thank you so much. Chiokwembe, I hope that also answers your question. We can now get to your questions, Livingston UTH. Ray, Shemu, you wanted to answer one of the questions. Are you able to?
Thank you so much, Chair. Thank you so much, Livingston UTH. It's a very good case and very informative and educative. I just wanted to attempt to one or two questions that have been asked here. So firstly, question one, what would have been the best approach at the clinic before referring for tertiary care? So at the clinic, we know that clinics do offer primary health care services. So the best approach would have been giving health education messages to this client on what STIs are, and the importance of seeking treatment early, and also giving HIV testing services. Like for example, in this HIV that was detected at tertiary level could have been detected at the health clinic. Besides that, the other information would have been that this client needed also to be offered social network testing. This is in response to question 2, which is talking about how to approach the issue. So when we give social network testing to this client, you find that to be able to reach out to a lot of KPs in the community and be able to offer the HIV testing services and also other preventive and promotive healthcare services. So if we do this well, we do it well, we create a very good rapport, you actually find that we won't be able to lose this client. The client won't be lost. So if all these things would have been done at the clinic level, because this is where the client is actually coming from, would find that we can reach out to many and be able to treat this client without losing her. Because even if we lost this client at the clinic level, since the client stays within reach, we'll be able to reach to this client with ease. Thank you so much.
Thank you so much, Ray, from Lewanika. I've seen there's quite a number of other questions, Dr. Paul, in the chat box. Even as we endeavor to answer these questions, please take note of the other questions that are coming in around the case. And you will do well to also just attend to them in the chat box because we may not have time to go through all of them. But we are now interested in looking at how we can help Livingston in management of this case based on the questions that they've asked us. I think one of the Daka from Chifundo Clinic is saying, since the patient is a non-KP, there's need to engage the community liaison officer and peers, preferably from the referring local clinic, for easy tracking of the patient and possible contacts. This, I think, ties in with what Ray was saying just now, that you will need to actually get these contacts for these clients. And I think I saw another one, Lucky Lungu also said the same thing, asking about whether information of her residence was collected and, contacts, social network, so that you can easily trace her. I've seen a hand from Grant. Grant, you can go ahead and unmute.
Yes, good afternoon. Good afternoon.
Good afternoon, thank you. Yes, please, go ahead.
Yeah, I also want to add a voice to... Yes, please. I also want to add a voice to the management of this client, the KP. The sex workers, they have places where they... Am I audible?
Yes, you are audible. Please go ahead.
Yes. So what I'm saying is, usually the sex workers, they have places where they congregate, where they sleep. And these places are called, that's where we find the queen mothers. And usually there are many of them that stay in those places. So what is needed is to approach these places where they sleep. You approach the queen mothers, and the queen mothers will arrange for a meeting with the sex workers. Because what they need is to have information on STIs. For as long as they do not have that information, then they will always be going out there and doing things carelessly. And moreover, when they know that they are having STIs, this person who has an STI is feeding the market for the other sex workers. So the moment you give them that information, they know that if the other person has an STI, the same person that gave that STI to this sex worker can also be a client to the other sex worker. So they need to have this information. And once they have this information, they'll easily be bringing their fellow colleagues, the sex workers, to the health center. And as such, you'll be able to track their clients. And by so doing, means that you are going to control the transmission of STI to these sex workers. I submit, Chair.
Thank you so much, Grant, for your comment. And indeed, we really need to, it's not only the clinical management that we are concerned with, especially when it comes to STIs, but we should also go out in the community. So Dr. Paul, there's quite a number of advice and questions in the chat box, whether your team was able to do a high vaginal swab for further investigations, whether you did the urine MCS, and Dr. Chanda Humphrey again from Matero sub-district is also asking about whether she was screened for other STIs, because as you may know, STIs will occur concurrently. So I can see a comment from Jacob Ngambi saying the patient was our index case. I believe Jacob Ngambi is part of the team in Livingston. So we needed to do partner notification services with contacts and social network addresses were collected and entered in the index register. So we needed to screen her for other STIs like Hep B. Being a non-KP with syphilis and loss to track also tells us the counseling skills at the hospital needs to be improved. I hope you get some of that, Dr. Kalombo. Do we have any other comments before I invite the panel of experts to just give their final thoughts before we get into the didactic presentation. Any other comments? No other hands I can see. Dr. Chitalu Chanda, are you able to unmute and just give some thoughts around this case?
Good afternoon. Am I audible?
Yes, Dr. Chitalu, you are audible. Please go ahead.
All right, great. I've enjoyed the discussion greatly. It shows that the clinical care is actually going to be is going to be excellent for the next patient that comes there. I want to start with the last comment that the last presenter, or I think Dr. Chanda has said from Matelo, that if you have one STI, you need to screen for the others. That's a brilliant comment. And probably if you are thinking about such a case, you're thinking of syphilis, you need to screen for HIV, you need to screen for hepatitis. And this is because some STIs are preventable. Sorry, there's some background noise. Somebody can mute that person for us. Thank you. So like I was saying, I think I'll start with the last comment that was actually said that if you have a patient with you who has one STI, you really need to think about the other STIs because the routes of transmission are very similar. So you think about hepatitis B, you're going to think about chlamydia, you're going to think about gonorrhea, you're going to think about syphilis, you're going to think about HIV. I'd probably just say if you're going to miss others, you don't want to miss syphilis, HIV, and you don't want to miss hepatitis B. And it's very simple that these are actually preventable. While some are curable, others are not curable. So that's a great starting point. Secondly, I think that most of our patients will be seen from primary healthcare setting. It's very, very important that you have a plan of referral for this patient. So if you can't do the test, you've thought about the differential of a syphilis or hepatitis, refer them to an next facility where they can get the service. And that will make sure that your patients have access to a service. I think that there's a didactic just talking about approaches to STIs. Broadly, you can think of approaching them as syndromic, meaning that you're going to think of it as a discharge or an ulcer. Regarding our case, it's very complex that we just have an RPR which can result from anything and everything that causes injury to a blood vessel. So we needed to confirm that this RPR probably is going to is going to ulcers and an RPR. This is probably syphilis. The next step for you to decide is when to treat and when to monitor. So you see that this patient coming for weekly injections, the plan was for injections. It was a challenge. We need to start thinking about, is it possible that we have oral outpatient options? For now, standard of care for treatment is just a penicillin, which we needed to ensure. So we really need to be aggressive into contact tracing and find this patient and make sure that they get their doses of syphilis. Now, with syphilis, some ulcers will actually resolve without treatment. So you might use clinical response as a cure. He said you have titers. Because you can use the titers to guide you if a patient is responding, recurrence of the symptoms occurring. So you need to monitor these patients for up to almost a year if they're HIV positive. I think that probably the other thing I just wanted to say is that I think STIs are preventable and there are various routes of prevention of the various STIs. So if you think about HIV, we know PrEP is there. But if you think about hepatitis B, there's a vaccine for hepatitis B. There's no vaccine that will be used to prevent syphilis. but there is also a role of certain drugs that can be used for post-exposure prophylaxis, which I hope will be discussed in the didactic. I think that's a mouth for now, and a great case and great presentation and great discussion. Over.
Thank you so much, Dr. Chitalu. Indeed, you've touched on very important things. These STIs really STIs sexually transmitted. So the presence of one might tell the presence of another, as also spelled out by Dr. Humphrey Chanda. Do we have Dr. Teddy Kajimoto? Dr. Teddy is one of our other experts. Dr. Mundia Mwitumwa. They will join the discussion as time goes. We are just looking at some of the other comments in the chat box from Arthur Biemba, Livonda Rural Health Center. Looking at the VL results, she seems like a compliant client. Should tracing fail, then we use the ART department, who should be on the lookout because she'll definitely come back for a refill soon. Words of caution also from Mimisha Siamwaya. It's important to do what we can when we have the client with us before we allow whatever investigations need to be done, because when we let go, these clients don't come provided they feel fine. And sometimes I have heard that benzathine penicillin is quite painful. And it could be that maybe it was too painful and she couldn't come back for the third one. So Mimisha is just telling us to do all that we can during the first visit. And Dr. Irene is saying emphasis on combination prevention for key populations is key. Also emphasis on using condoms at each sexual encounter. So please do provide condoms as well as lubricant. I can see Dr. Prince Sapuhuka is quite active in the chat box, also responding to some of the concerns. Thank you so much, Dr. Prince. That's what we expect, that even as the discussion is going on, some of these other comments can be attended to. My time is 3:13. I'd like us to get into the didactic presentation. Dr. Malan. Are you with us?
So I don't have much to say. I think most of the questions that are there may be answered in the chat that I'll get.
Okay. Dr. Malam, will you share your presentation?
Pardon?
So, Dr. Malan, I believe you are using Prince gadget.
It's okay if I start with the presentation.
Yes, please. Go ahead. You can start the presentation. There were quite a number of gadgets that were on, and we were getting a lot of feedback. But I think we can get you clearly now. Please go ahead.
Okay. Good afternoon, everyone. I'm in a very hot place, extremely hot, no aircon. Livingstone is hot. I think climate change is real, and it's just something else. So my name is Malan Malumani. I'm based in Livingstone at Mulungushi University, but I get to see patients for the hospital as well from time to time. So today I'll just cruise through. I hope I'm clear. Any feedback?
Yes.
Am I clear? Audible enough?
Yeah,
Okay, thank
audible
you.
now.
Okay.
Yes, you are
So
audible.
I'll briefly talk about approach to management of STIs. So we'll just streamline to some common STIs and their role in the prevention of HIV transmission. And I hope I won't bore you. So our learning objectives today, one will be to review the burden of STIs in Zambia, to discuss the clinical presentation of common STIs in Zambia, and to discuss screening, diagnosis, and treatment of common STIs in our country, and also STI screening and management as a tool for HIV prevention. Okay. So before we go into the meat of the training, I'm sure most of you have come across STIs, or I should have phrased this question as, has any one of you suffered from an STI? Can I see by show of hands? And if yes, how did they go about it, or how did you manage it? Did you treat yourself, or did you call a colleague to have yourself treated? The third one is, what are some of the common STIs condition that you have diagnosed in HIV patients, or even in those who are not HIV patients? So these are some. Okay, and the last one is, if one were to think of or think about STIs and HIV, what comes to their mind? Do they come together, or does one promote one getting the other one, or how do they relate? Okay, so these are some of the things that we may need to be asking ourselves. Why are we talking about STIs? If you follow ZNBC, I know most of you watch Netflix. In Mansa, there's a crisis right now. I think the DHT there was on TV talking about syphilis in the newborn. Solwezi was on the news for wrong reasons. Lots of STIs, lots of syphilis in Solwezi. So I think there is a lot of work for all of us. So a brief introduction to our topic. STIs have a profound impact on sexual and reproductive health worldwide. Okay, the management of STIs plays a crucial role in HIV prevention due to the interconnected nature of these two public health challenges. Okay, And it's very important that effective management of STIs, management of STIs is a fundamental component of comprehensive HIV prevention strategies. By addressing both the biological and behavioral aspects of transmission of STI management, it contributes significantly in reducing the global burden of HIV. So these are issues that we must bear in mind. So this presentation will focus on management of common STIs for HIV prevention in Zambia. So the epidemiology and trends of STIs globally as of 2021, World Health Organization estimated 1 million acquired STIs. They acquired STIs globally on a daily basis. So on while we are still in 2021, COVID overtook us. So most of these organizations which monitor and look at these other diseases had been sidelined by the pandemic that we had. An estimated 376 million incident cases of chlamydia, gonorrhea, syphilis, trachomatis was in this reproductive age group of 15 to 49 years. That was between 2009 to 2016. That's a huge number. And also an estimated 414 million people are infected with herpes simplex, type 2 at any time point. And about 291 million women are infected with HPV at any point of time. So these are huge numbers and require all of us to be active in trying to keep the issues of STIs. And recently, cases of genital ulcers in the sub-Saharan Africa were most commonly due to herpes simplex virus and not syphilis. So there's a bit of shift in the way we are experiencing these STIs. At one point, you find this one is up. At that point, this other one is up because of the measures that people put across, and the screening tools that are there and whatnot. So about 70 to 90% of genital discharges were due to chlamydia and gonorrhea. And we must also take note that drug susceptibility patterns for gonorrhea have changed in the past. So what used to work then right now may not work. So I think in our HIV guidelines, protocols, issues, Ciprobit has been phased out in treating gonorrhea. So unless otherwise, you can still try and give, but there's a pattern, a shift. So just in Zambia, this is the trends of HIV and STIs in Zambia. Like I mentioned, Solwezi was on news, Mansa as well. Now, if we are seeing STIs, in newborn babies being passed on to newborn babies, meaning we've been caught pants down because antenatal care I'm sure that they screen for syphilis. Okay, we are not sure where the problem is, but these things now, we are seeing them even in the very young. So if you can also check, I've done a paper on condyloma acuminata, which is genital warts in the young, the dilemma of sexual abuse versus none. So we are seeing also these warts in children. So it's an issue where I think our systems are failing us, or there's something wrong, which I think as a team we will discuss and see how we can find solution to that. So Zambia's HIV prevalence rate stands at 11.1%, with an estimated 1.4 million people living with HIV and 1.1 million people on treatment, which is a fairly good thing, with Livingstone recording the highest rate of HIV prevalence at 25. Now, this, for obvious reason, it's a transit town, so tourists, transit, yeah. Gonorrhea, so most common STIs causing discharges more in males at 70% and females 64%. In women, we should also look at the issue of asymptomatic cases, okay? Okay, and you can have non-gonococcal urethritis, cervicitis, they're also common, okay? And for ulcers, already mentioned that herpes simplex type 2 was the commonest cause of genital ulcers, okay? Syphilis was detected among 6% of those who had ulcers. Genital warts, they make up about 70 to 80% patient presenting. This was a study that was done at UTH. Okay. And the worst part is that most patients will present very late, especially those with warts. They present very late when the lesions are actually spreading. So we may need a lot of sensitization. So if you look at the trends, okay, you actually see that the numbers are increasing year by year. So from 204,000 to 303 in a space of 5 years. That's huge. Okay, 100,000 increase. So either the numbers are growing, the numbers are interacting more, or they are growing versus the little healthcare centers that we have. So it's up to us as a team to look at what are the driving factors in this issue. Okay, so for us to understand the link between STIs and HIV, there are factors that we may need to consider. One, biological factors such as having genital herpes, syphilis, gonorrhea. These create genital lesions. They will lead to immune activation and inflammation. These they tend to compromise the mucosa integrity, providing entry points for HIV virus during sexual intercourse, thus increasing the chances of one of these individuals getting infected. Okay, so untreated patients who be with untreated STIs, they are more susceptible to acquiring HIV. So this is the most significant relationship that we may need to take note, that if we have untreated STIs, they will increase the chances of visa. So if your partner is HIV positive, you are negative, but you have these STIs, vice versa, you may end up, it's easier for you to get this HIV. Behavioral factors, high-risk behaviors that contribute to STI transmission, such as unprotected sex, having multiple sexual partners, inconsistent and incorrect use of condoms. These also associated with an increased risk of HIV and STI transmission. So the other thing is the overlap in key population. So you find that in certain communities, for example, in Livingstone, you have sex workers, intravenous drug users, and others, these key population people. So they are the higher risk of both HIV and STI. Okay, so having a combination of all these three, you are a sex worker like our client who was also HIV. Then if you also put in the issue of behavioral factors, okay, whether they use condoms, okay, and whatnot, so puts one at a higher risk of getting these STIs, okay. So national STI and HIV prevention strategies. So this has been possible through the MOH, National AIDS Council, and other cooperating partners like Global Fund, PEPFAR, who have been supportive in the various districts where they do VMMC, voluntary medical male circumcision, PrEP, the provision of PrEP, the condom program, where there are jokes that people make at times and say, what is that company? That one, that company that comes with a truck and just brings MSL. MSL would drive from Lusaka to the Livingstone and just bring boxes of condoms, which is a good thing. So, yeah, but I think we could do more where in bars, in drinking places, I think condom distribution should be done, and which is important. The sex workers could be given boxes or strips of condoms. I think it do help. Okay. So adolescents, girls, and young women and the key population can be taught on STIs and how to practice safe sex issues. So these are also key, because if one doesn't know how to use the condom properly or what it means to practice safe sex, okay, then our population is doomed. So creation and maintenance of district ART and STI safe spaces, I think this is also important, because we are noticing an increase in the population in our communities, in our districts, and the creation of these centers, okay, these integrated sexual health services centers, they are still they're still limited, okay. Yeah. So so at this point, we'll just talk about diagnosis and treatment of some of these common STIs. I must mention that almost all of us, I think we know these things, but at times what we lack are the supportive services? Is it kits, testing kits, or the medication? Okay. Because at times you may find that a client comes to the hospital, this clinician sees them, the next thing they'll tell them, look, this is what you have. We are thinking is this, but we don't have the kit to use for testing. Go to this facility. They go to this facility, they test, it's positive, they have to go back to another facility for either injection of the drugs and whatnot. So these stockouts and whatnot create problems for the patients and also the clinician. Okay, so some of the conditions that we look at in brief, genital herpes, syphilis, gonorrhea, chlamydia, trichomoniasis, genital warts, molluscum contagiosum, hepatitis B and HIV. I will not look at them, but we get to see some of these cases. So these ones, the ID specialists, I think these are huge and big topics, which I think we should leave them to those people who play with infectious disease. Okay. Yeah. It's the bread and butter. So herpes simplex, commonly caused by herpes simplex virus type 2. Though we have 1 and 2. 1 is usually on the oral, on the mouth. Yeah. And 2 below the belt. So you can just say 1 above the belt, 2 below the belt. But these days, the way people practice sex, you find someone has got an ulcer. Someone has got an ulcer on the lips, which could be type 2. Okay. I think I hope we are aware how people practice sex these days. Blowjobs, those things. So the lips and the genitalia are the sites that are seen. Okay. So clinical features, patients who present with multiple painful grouped vesicles on an erythematous base. So incubation period may vary up to 2 weeks, 5 to that's okay. What we may need to know is that there is no cure for herpes. Once you get it, you have it for forever. And right now we've been seeing kids having these herpes, okay, because of our culture, the way we are. Times the parents are there kissing small kids, relatives, that, and we transmit these things. Okay, so suppressive and symptomatic therapy is effective. So some of the drugs that we could use are cyclovir, and others, if you're allergic to these, like foscarnet and all. Okay. So syphilis is caused by T. pallidum. It has got stages. Primary, where one can present with an indurated painless chancre or ulcer, which may heal even without treatment. And if that goes unnoticed, some years later, years to months, okay, they may present with secondary syphilis, which is it's a generalized rash. Patient may have also lymphadenopathy. Okay, and amongst the symptoms that they may have is the copper pen sign. I think you can see in the picture here. One would tend to have these nice round lesions, okay, on the sole of the feet and on the hands. These patients are highly infectious, okay. So sleep with them, yeah, they're gone as well. So this is secondary syphilis. Okay, you can present with alopecia, that is patchy lesions on the head, on the scalp. You just see your hair is just falling off. You have a patchy thing on the head. Okay, so that's also another sign of secondary syphilis. Okay, you should also ensure that one gets checked for this alopecia. Syphilis can cause that, but also autoimmune conditions like alopecia areata can cause that. Even fungal infections like tinea capitis can give a similar picture. So you don't go around just looking at people's scalp and say that's syphilis. Okay, so we always need to investigate. So I think even the case that we had, the patient had condyloma lata. And these patients, with just the jab, they get to resolve very well. And most of the clients may think actually that these patients have got genital warts. These ones caused by HPV. Tertiary syphilis affects neurosyphilis, can affect any part of the body, cardiovascular, cutaneous manifestations, and whatnot. So they may present with GPI, genoparesis of insane, dosipedalis, and these other things. So these are patients who've been neglected, or they decided not to go for treatment. However, in the HIV community, those who are HIV positive, these conditions these stages, you may find that one has got a chancre within weeks to months. They end up having neurosyphilis. Okay. So the tests that we can do, okay, we can do these non-treponema tests. Okay, these are not specific for just syphilis. They can be positive even in other disease conditions, even autoimmune conditions. RPRV, DRL. These are RPR is what we have is a screening tool. Okay. So, and like in our case, I think the best would have been also to confirm it with titers. Okay, so that on subsequent review, you actually see a drop of these titers to show that yes, treatment is happening. Okay. These specific treponema tests, okay, these highly advanced centers, I think maybe UTH, Livingstone, we don't even do these things. So yeah, just an issue of academic kind of. So drug of choice is benzathine penicillin. So in cases of people who are allergic to this, azithro can be used, but you give it for a longer duration. Doxy, tetracycline, this can also be used, okay, but duration is key. You have to give for a longer duration, this no less than 21 days, okay, for you to cure these things. Gonorrhea, it's a leaking disease, okay. Most clients who actually come and tell you, I'm leaking, the men mostly, and women may just tell you, no, I have this purulent or this discharge. Okay. It's worse than normal. Most women are very particular about these things, so they will present early. Okay. We may have a bit of dysuria, and like we had mentioned earlier, some women may be asymptomatic. Okay. Up to 50%. So it's very important that if a man who may say they are symptomatic, as long as they've had contacts, you get to treat them. So labs, microscopy, to isolate these antigen tests, culture sensitivity, NATs can also be used. So treatment, cefotraxone, cefotaxime can be used. Okay, cefixime, okay, cefuroxime. You could use all those things. Okay, yeah. And we must take note that improper use of these drugs can lead to resistance. So when you're giving a dose, you're treating this, you ensure that patient adhere to the treatment protocol. Okay. Chlamydia, it's caused by Chlamydia trachomatis. Okay. So patients may complain of genital symptoms. Okay, urethritis, which will have dysuria, urethral discharge, urinary frequency, pass in urine, having agency with purulent or mucopurulent urethral discharge. Okay. It may also present as a reactive arthritis, okay, which is a triad of three things: arthritis, urethritis, and uveitis. May even involve the part of the eyes. So in women, you may find that they will have cervicitis, okay, and mostly asymptomatic to mild symptoms. Okay, may have some vaginal discharge, bleeding, okay, and also some postcoital or intermenstrual bleeds. So tests. So this mostly big centers will be the one who can get to do this, but I know there are these small tests that you can do for thing. Nucleic acid amplification test. Okay. Treatment, doxy still works azithromycin, cefotraxone. I must mention that I've been seeing some cases that are resistant to this doxy and cefotraxone. Okay. What has been working? I think we may need to do just resistant pattern is levofloxacin. I think it has been working well, especially for these patients who've given the issue of using cefotaxime, and doxy, cipro. Levofloxacin has worked well for them. Trichomoniasis, okay, it's caused by the protozoan T. vaginalis. So these may give a diffuse white to clear, typical frothy, malodorous, or yellowish to green discharge. This on the vulva, the private parts, may have some dysuria, okay, urethral irritation and all. So basically do a microscopy on a wet mount, you see these protozoan. Okay. You can also do Trichomonas rapid antigen tests. So treatment is metronidazole 2 grams start. So, or you can also just do the normal flagyl dose. Is okay. 400 TTS for 5 days to still do the trick. And I think that's the reason in the past we would have the tempo therapy where anyone with a discharge, you give Cipro, metronidazole, and doxy. One of them will treat one thing, but that is not cost effective and it creates resistance. So that's the reason we are shifting from syndromic treatments to etiological, where you actually do the investigation. Genital warts. Chair, these people here are not providing me with water. Is it in order?
If it's Prince, he must provide some water. I know Prince very well.
Yeah, I'm with him here. We are just waiting in this, I don't know what you call it. So what's human papilloma virus? Okay. They are worse in people who are immune suppressed. Okay, and that's the picture there of what's. So we should take note to distinguish between what's, which is condyloma acuminata, and also the condyloma lata, the one that you get in secondary syphilis. At times they may look alike, except that the one in secondary syphilis, they may be producing some seropurulent discharge. They may be more wet. Okay, yeah. And like those ones, you may find that even on oral antibiotics, you can discover that those things have actually gone in, because you may find that one starts, starts just these antibiotic, doxycycline and whatnot, that will actually reduce them. And that's the reason where we've had patients where someone comes with what? Because their friend or someone they know had similar lesions and they got an injection. They also just say, just give me that injection to go away. And they persist, okay? So these may be indurated or keratotic, fleshy, colored or gray growth. Others may be hyperemic or hypo, okay, in color, where they have very light, as if someone has got vitiligo, like, okay. It may have finger-like projection, the filiform type, or smooth, flattish kind of, okay. So for me, I think what I recommend is, if we can teach our patients how to identify this, the earlier they identify or they present, the better the outcomes. Okay, so treatment, you could use podophyllin paint, comes in different concentration. Okay, those that you can use just once weekly or once daily, depending on concentration. In good centers, they have cryotherapy. This is just cryo using very cold, it's a gas, cryo, liquid nitrogen, okay, which can freeze that. Yeah, high concentrated salicylic acid may work. Okay, cauterization can be done. Okay. I also did a small write-up on how you can manage these small lesions, especially those in rural setups. Okay. though I use molluscum contagiosum to just describe how one can treat them using the readily available techniques if you don't have a if you don't have a cauterization machine. I think it's there on on the internet, treatment dilemmas that you may have. Okay, Imiquimod cream expensive, but it works, especially for women or men. Women where you find that they have inside the vagina there. They have those lesions where you've cauterized, but there are some which are still lingering inside. You can do application of Imiquimod once or twice or 3 times weekly for up to 6 to 8 weeks of application. So that works. In certain centers where I've been, they also do what we may refer to as graft versus host kind of treatment, where you basically get to pick a small piece of okay, or lesion, you cut it from whether it's in the private parts, and you do it for those where the lesions are a lot, and you plant it on any part of the body, maybe on the thigh. You just open as if you are planting something in the soil and put a stitch there. So when the body is trying to heal that defect, to realize that this lesion that you've planted there is abnormal. So it will produce antibodies against that. So it will now act like a graft versus host kind of, and it will tend to shrink the lesions. Other centers, they use laser CO2. Okay, you can use that, and I think that's what we should be gravitating towards. Okay, so molluscum contagiosum caused by epoxy virus. It's epoxy virus, molluscum contagiosum itself. Okay, in children, it's the commonest. It's a childhood disease. Okay, but in adults, mainly it's through sexual contact. Okay, and in those who are they may look like pimples as they are starting. Okay, but as they grow in size, they'll be dome-shaped, round, firm papules. They may have a skin color type, especially in darker skin people, like you can see there. Okay, and at the center, you may see what is referred to as central umbilication. And when you express it, it will produce this caseous material. So treatment similar to what's curettage, cryo, cauterization, may use podophyllin, but may take forever. Imiquimod does work if they're just starting. ART also, yeah. So we must take note that they are self-limiting. At times, even without treatment, the body may actually just fight them out. So in centers where you may not do anything, you can do watchful waiting, and maybe you advise them to avoid pressing them, because you can also do self-inoculation. You can reinfect yourself. Okay, so basically why we need to know these STIs and treat them appropriately is that they have serious consequences, complications, okay, both in males and in females. Okay, and if untreated, like in males, they can lead to all those things epidemiological strictures. A study was done at our hospital here in Livingstone, one of our students, and they found that the commonest cause of urethral strictures was actually gonorrhea. Okay. So in worser situation, they can cause sterility both in males and in females. Fistula, bubble, arthritis, prostatitis. Okay. Females can lead to PID, lymphedema, ectopic pregnancies, miscarriages. Okay. And also STIs, like we mentioned, they predispose one to getting HIV. So STI screening is paramount. So screen partners of individuals diagnosed with chlamydia, gonorrhea, trichomonas vaginalis, syphilis, or hepatitis B and HIV. Very important. You may need to screen for that. Symptomatic females of male partners treated for chlamydia and gonorrhea should be treated regardless of the lab results. Okay. Sexually active individuals should undergo screening for syphilis and hepatitis B. I think people have been doing well with the syphilis, but with regards to hepatitis B, I think we may need to make it a routine in some homes. It's only done for those who are either donating blood and whatnot, or an issue where someone is really sick and the clinician just thinks of just doing hepatitis B for the sake of doing a septic screen, a wake up of some sort. So talking of future directions, I think what will be best is integrated sexual health services. Okay. These things, they are important because integrated sexual health services where you find, it's like a one-stop shop where you find almost everything in one place. You have your mini lab. I think the way UTH dermatology STI clinic does their thing, I think that's a model that we should have, where these RDTs or these STIs are there within the facility, because at times the burden of telling someone, okay, we think it's this, but we can't treat because we want to follow the geological thing, go and test, then they go to the lab, they find, oh, this test, you come with an empty result, not down out of reagents. Then this person has continued to live. So I think an integrated sexual health services will be better. I think it's something that should be looked into because it offers a holistic and comprehensive approach that combines various health care services related to sexual health within one work space. Okay. And the goal is to provide these individuals with a seamless access to a range of services that addresses not only the sexually transmitted and HIV, but also other issues of sexual and reproductive health, issues of condom program where you provide these things, and also contraceptive care if there are those that may need termination of services and whatnot. So I think this is what we should be looking towards to. Okay. And these integrated services, they contribute to a more efficient client-centered care and this can enhance health outcome. So one patient walks in one space, they get everything they need, no need of referring them to another facility and whatnot. Okay. So these are some of the components that you get to find in an integrated sexual health services. So STI and HIV counseling, those can and should be provided in that STI clinic. Counseling, education, treatment of STIs almost there, and then you don't need to start referring someone to go to another facility or to go to the pharmacy. Should have a pharmacy just there, and then prevention services, condom distribution, and PEP, offering family planning services, screening for reproductive health issues, okay, cancer of the cervix and all this, maternal and child health, okay, can be provided in that. Okay, adolescent sexual health services, where we look at the special needs of these people, counseling and whatnot. GBV, okay, and what is also paramount and important is community outreach may need to be going in these communities, especially these active zones, Solwezi, Mansa. I think the community outreach and education programs should be rolled out. So challenges and solutions, I think this is something that I would love to hear from almost every other facility, where if we could register our challenges and possible solutions that we may have towards these things that you're seeing on the ground. And I think you can share with the moderator so that some of them, I think, could be addressed. So it just goes beyond us sitting and listening about the STI thing. So in summary, I would say all health workers should be reoriented to STI and HIV management, especially we're having different schools that are coming in and whatnot. So I think in the past there was that compulsory HIV guidelines, whatnot, which could be taught to almost everyone, but that has been streamlined to those who are in that specialty. But we must acknowledge that patients meet almost the first person they'll meet is those community health workers, or these, you call them CDs, huh? Yes. So I think everyone should be reoriented to these integrated sexual health services, should be introduced or reintroduced in our communities. Okay, these spaces where people can get these facilities. And the other point is that clients who can treat STIs at a higher risk of contracting HIV and vice versa. Those with HIV, they are at a higher risk of getting some of these STIs, okay, if they remain untreated. And we've all acknowledged that STIs in Zambia are on the rise. It's all over the news. And I think we must act fast. I think I'll end here. Submit.
Thank you so much, Dr. Malan. I'm sure the network can tell that you take your bread and butter very seriously. because of the amount of time you've taken to really belabor the points that you have, and we really appreciate this session. From the chat box, it was buzzing with a lot of comments. Thank you so much, Dr. Malan, once again for the presentation. It was very clear and it was straightforward, and we could follow along. I can see a lot of people are asking for the presentation, and be rest assured that the presentation will be shared, especially on our WhatsApp platforms. Unfortunately, looking at the time, it's 4:10. We're supposed to end at 10. It's 4:10. We're supposed to end at 4. But as you can tell, this was a session that really kept the network glued, and we are thankful for that. This presentation will be shared on various WhatsApp platforms. You can find the recording of this session on the MOH Echo YouTube page, so that you can just go over some of these things. But definitely the presentation will be shared. I am happy to have noted that we have a lot of representation from the PHOs, the provincial health officers. Dr. Mwape was with us on with the LPHO. I saw Dr. Charles Fanaka, the PHS EPHO. I was with him just a few days ago. I also saw quite a number of DHOs that attended: Katete, Pika, Chibombo, Mongu, and Lobezi. So we'll be able to share widely, and wherever you are, you should be able to get these presentations. Dr. Malan, just one question. Someone was asking, Chinyama Feda was just asking, in the absence of benzathine, penicillin, and ceftriaxone, a second line for syphilis, can you give erythromycin QID for 14 days? Dr. Malan, what is your comment on that?
Yes, it can be given. Erythromycin, tetracycline can be given, even I think for a longer duration than that. Yeah, but the best drug of choice, usually it's in places where this one has this condition and the best option you don't have, or they are allergic to those. So if they've clearly spelled it out to you that I'm allergic to this drug, do not go that route, but you can use the alternative. Yes, can be given. Then the most important thing is to recheck after your instituted treatment. So 14 to 21 days, I think that would suffice.
Thank you so much, Dr. Malan. And yes, thank you so much. And we are way beyond time, and I wouldn't want to keep our dear listeners any longer. So unfortunately, we won't take any more questions at this point. Dr. Malan, do you have any closing remarks?
Well, I think to the powers be, the request is, I think we may need to evolve to integrated sexual health services. If we could go that route, and creation of STIs and dermatology centers or units where they can actually groom or train people who can be focal points in these district communities. I think that will help. The fight is for all of us, and we should take it seriously. STIs are on the rise from the trends we've seen, and we should give it the necessary attention that it needs or it requires. Thanks.
Thank you so much, Dr. Malan, and thank you for the wonderful presentation. Dear listeners, I thoroughly enjoyed this session. I apologize for eating into your time for other programs. And I just wanted to say thank you all for those of you that have stuck around until the end. So we've come to the end of this session. We were looking at just really the approach to STIs in relation to HIV and how we can prevent them. This, as I said, this presentation will be shared on various WhatsApp platforms, on our Slack channel. So be on the lookout. You will definitely get it today. For our next session, we invite you once again. We will have our next session next Monday, 14:30 to 16 hours, and we'll be looking at the new shorter treatment regimen for TB in children. What are the lessons that have been learned from pilot sites? I know Dr. Mutumwa, Dr. Monica, and the STIs team are very active on the TB loan, and they'll be able to probably share some of the lessons that they've learned. With that, I want to wish you all a pleasant rest of the day, and thank you for attending. Good day.